So with this basic background of what AUB is and how we classify it, let's see how we would present a case in the exam. So as usual, when you start with a case, you will be telling the name of the patient, the age, whether she is working, housewife, and her address, the socio-economic status, and then we will move on to the presenting complaints. So generally you would, if she has how many children she has, a para 3 live 3 or para 2 live 2, that would also be included in this aspect. And then the next thing would be, what are the presenting complaints? She is coming to you with complaints of irregular bleeding PV for the last how long? So now, just like any presenting complaint that you have to know the origin, you have to know the duration, you have to know the progress. Now, when you take a history of bleeding, as I said, you have to pay attention to all those factors: regularity, cyclicity, duration, volume, and that has all to be documented. When you're asking her what are the complaints, she might have some other complaints like lower abdominal pain, she might have discharge PV, she might have dysmenorrhea. Those have to be documented, and all these complaints, again, they need to have an origin, a duration, and a progress. So if, for example, she's having irregular bleeding PV, now she's having heavy prolonged bleeding PV, and then it's along with that she has started to have dysmenorrhea. So that tells you that there's probably some uterine pathology, because there's also dysmenorrhea. There is no dysmenorrhea, it's just painless bleeding, then this bleeding could be due to some other factors. So it is important to know what are the other symptoms that she has. Now when you record the history of the bleeding, go in detail about the frequency, the volume, the regularity, and the duration. The volume also you have to be careful. Like for example, some patient might tell you that she has bleeding for 10 to 15, 20 days every cycle, and then within another 5 or 6 days she starts her next period. Now in that case, if she says that she's having this since the last 6 months, so you have to really think, is it possible that somebody would have bleeding for 25 days in 30 days and then not meet a doctor for 6 months? So there is some reason why she has not met the doctor for 6 months. Then when you go back and take the history properly, you might find that she has just a little bit of spotting for the first 5 or 10 days. Then she has bleeding for say 6 or 7 days, which again is not too much in volume. And then she has again spotting for 5 or 6 days. Then within a gap of another 5 or 6 days, she starts spotting again. So this actually is a very irregular kind of a pattern, as most probably there is no ovulation occurring, there is just this patchy bits of shedding and regeneration which is occurring at a random, in random areas at a random pace. Okay, so it is very important to take this history. Similarly, you will have patients telling you that I get my periods twice every month, and when you actually inquire, she might be having one period on the 1st and the other period on the 28th. Now, is that really abnormal? So it's important that you take this history, and then with just the history, sometimes you may be able to reassure a patient, or you may be able to find out what the pathology is. Then the other thing that you have to do is the treatment history. So when someone tells you that she's been having this problem for 1 or 2 years, obviously she would have consulted a doctor. So then you must find out what are the tablets she has taken, and then you have to know. So in order to, from the history, identify what are the tablets she has taken, you must know what are the tablets that we can give. So generally during the episode of bleeding, if she has taken 1 or 2 tablets 3 times daily, this is most likely to be tranexamic acid or mefenamic acid, NSAIDs, etc., that we give to control the bleeding. Suppose she is taking tablet which is from day 5 to day 25. Then this could be OC pills, which is a combination of estrogen or progesterone, or it could be just progesterone. How do you make out which of these it is? The OC pills will come in a pack of 21, most probably with the Monday, Tuesday, Thursday, Friday written on it. Okay. The medroxyprogesterone acetate or the progesterone only tablets that you get, they do not come in a cyclical pattern, they just come as strips of 10. So with this kind of information, you should be able to find out what she has taken, whether she has had to take any injections to control the bleeding. All this will give you an idea as to whether what is the severity of the bleeding that she is having. Does she get dyspnea, fatigue? Is she taking iron tablets regularly? Because you might find that she is not having anemia now, but she's saying she's having heavy bleeding. It could be because she's been under treatment, she's taking iron tablets most of the time. So whatever blood is being lost, she's replacing it. So this history, treatment history, is very important, and it also should tell you, like from the point of view of treating the patient, if she's already taken a course of all these tablets, then you have to go to the next step. You can't start repeating all these things because you're not going to really give her any relief. So it's very important that you take the treatment history. Now, whether the bleeding is bothersome, there are 3 questions that you need to ask to identify whether this bleeding is actually bothersome. So you must know, how much do you bleed? Is it really a lot? Do you bleed at night? Do you need to change your pad at night? Do you soak your bedding? Okay, so that tells you that the bleeding is really heavy. Does it affect you physically? Like for example, when she passes those clots, there might be pain. So if there are large clots, similarly if they have episodes of fainting, breathlessness, etc. during the periods, that means that there is actually a loss in the volume of the blood. And does it affect your daily life? Now there are many people who will tell you that the bleeding is so much that they prefer not to go out. They prefer not to attend weddings or parties, or they take leave from their work. Okay, or they need help at home during that time because they just cannot get up from bed. Now that is bleeding which is affecting their social life. So even if the HB is not very low, you must realize that this is a place where you have to interfere. So you must identify how much the bleeding is and how much is the volume of bleeding. Then it's basically a question of what are the number of, how do you assess how much is the bleeding. So many times there will be patients who will tell you that they are having a lot of bleeding, but you find that they are not anemic. There is not much of anemia, they have not been taking much treatment. Now, when you look at it, they may be people who are very much finicky regarding their hygiene and just changing pads, every time there is a little bit of bleeding. So they are using 5 or 6 or 7 pads per day, but the bleeding is not much. There might be others who are not really very much into hygiene, and they keep that pad for as long as they can. So they may be using just 2 or 3 pads, but are having more bleeding. So these aspects have to come up in your history. There are various methods of assessing what is a heavy menstrual bleeding. Either you can use the number of pads or the passing clots, you can use a hemoglobin estimation, or you can use a pictorial blood loss charts that you have, and you can use menstrual calendars as well. Okay. So there are charts like this which quantify the bleeding. Like on day 1, do you have, you ask them to, you find out how much, like you have this chart, you give it to them and they can score it. So if there is just this much bleeding on day 1, that score will come as 1. Okay, and if there is a lot of bleeding on many days, then the score will come as 5 or 6. So accordingly, you can find out whether with the score, if the clot is less than 1 inch, then you take it as 1. If the clot is more than 1 inch, you take it as 5. So the number of tampons they use, the number of pads they use, with this you can have a scoring system. And if the score is more than 100, then definitely heavy menstrual bleeding is there and you need to treat. Now these are things that we may not use every day, but in case you have a problem, you cannot identify which patient is having heavy menstrual bleeding, these are techniques that you can use. Then we have to look at, now so this is a patient who is having bleeding. And she has come to you, you've taken the history. Now you have to take some negative history. How do you ask? What are the questions that you ask? Again, you have to have this list of palm coin in your mind. Polyp. What are the other things that she can have apart from heavy menstrual bleeding? If she is having a polyp, she can have continuous discharge period. Okay, which may sometimes be foul smelling, which may sometimes be blood stain. So that tells you that there is a polyp. So this is a history that you have to ask, whether there is intermenstrual bleeding, whether there is discharge. Okay. Then if there is a large fibroid, then there may be dysmenorrhea. So during the periods, she may have a lot of pain. So that dysmenorrhea tells you that there could be either adenomyosis or there could be leiomyoma. Again, when you're talking of endometriosis, that also is a condition where you might have heavy menstrual bleeding. Like usually the bleeding is not too much, but the pain can be more. So if there's dysmenorrhea, you will have to ask for dyspareunia as well. Because if there is dyspareunia, that means there is pain during sexual intercourse. That tells you that there are these deposits in the POD or the pouch of Douglas, or there is the ovaries are all adherent to the posterior aspect of the uterus, which is what is causing the coital pain. So that also tells you what could be the causes. Okay, then you have to look for urinary symptoms. If you have a large leiomyoma that is pressing onto the bladder, then the patient may have frequency, the patient may have difficulty in micturition. Then you have a fibroid like at the level of the, suppose you have this is the bladder, and this is the uterus that which is there, okay, and you have your vagina. So you find that the cervix is very much in relation to the posterior trigone of the bladder. So if you have a large fibroid over here which is pressing the urethra, you can have retention. So cervical fibroids, yeah. So sometimes you may have a posterior cervical fibroid, which sort of, it alters the anatomy and the uterus becomes retroverted, and this whole fibroid is pressing against the urethra. So you will get retention. So depending on where a fibroid is, you might have symptoms which are different. Then you have to ask for history of bleeding tendencies. Like for a girl who has had problems, when she goes to the dentist and she has a tooth extraction or something, she has excessive bleeding. That tells you that there is a bleeding tendency and you will have to look out for coagulopathies, thrombocytopenia, etc. Are there features suggestive of PCOS? What will that tell you? You have your ovulatory dysfunction. So when you take a history, you will have to ask her for whether she's having acne, does she have galactorrhea, does she have dark patches on her neck suggestive of acanthosis nigricans. So these on history and examination you will have to look for, and whether she is taking any drugs. So very often we find that when a woman comes to the clinician and finds that there is excessive bleeding, sometimes they are prescribed with hormones. You take progesterone for 3 to 5 days and come back to me is probably the instruction that is given by the patient, by the doctor. When she starts on progesterone, her bleeding stops. She doesn't go back to the doctor. So there is progesterone withdrawal, she starts bleeding again. So she thinks, let me take these tablets again and see. So she will self-medicate with these hormone tablets, and that is a recipe to disaster. So that is another thing that you have to find out. The only treatment that she probably needs is stop all drugs. Once you stop all drugs, her cycles resume normally and she may not require any further treatment at all. So is there any irregular intake of drugs is another thing that you have to ask for. So each time you're thinking of, you look at palm, you look at coin. Polyp, any other feature suggestive of polyp. Adenomyosis, dysmenorrhea, dyspareunia, all could be there with adenomyosis. Leiomyoma, there would be dyspareunia, there would be dysmenorrhea, there could be urinary symptoms. Malignancy, again there could be irregular bleeding, there could be weight loss, there could be loss of appetite, okay, or you might have a person in the family with so and so complaints. So that is other history. Coagulopathy, you look for any bleeding tendencies. O, you look for any ovulatory dysfunction. So, is there irregular cycles from before? Is there weight gain? Is there acne? Okay, these are things that you can ask. And similarly, for all of these, iatrogenic, very important, you will have to ask for the history of drugs. And with the fibroid, the patient may have lower abdominal pain. She will have distension, heaviness of the lower abdomen, backache, maybe swelling of the lower abdomen, and pain in the abdomen. So, that will tell you that there's probably a fibroid. So, these are things that you have to ask. Each time you are asking a question, you look at this list and ask for symptoms which you may have with each of these, and you are unlikely to miss any of these symptoms. Again, when you go to past history, what past history will you take? Similarly, you can ask for conditions. Has there been any similar history of bleeding before, where a DNC has been done and maybe a polyp has been taken out and sent for histopathology? Has there been any pathology before where she has been evaluated with a uterine scan, with a scan, USG, abdomen and pelvis? Are there thyroid disorders? Has she been treated? Is she taking on medication for thyroid dysfunction? Are there breast secretions? Because galactorrhea will tell you that there's probably discharge from the nipple. Okay, any surgeries, any bleeding during the surgeries? Like I said, usually it's a gum extraction, a tooth extraction or some gum surgery. Is she on medications? For example, she might be on warfarin because she's having a replaced cardiac valve, or she may be on antipsychotics. What do the antipsychotics do? All your drugs, they will interfere with the dopaminergic pathway, and you will have changes in the thyroid and the prolactin levels, all of which will interfere with ovulation. Okay, these women may even have galactorrhea because of the antipsychotics that they're taking. Then the other drugs that may influence the cycle regularity, the COCs, the progesterone, tamoxifen and steroids. What is tamoxifen? It is actually a drug that is given in cases who have been treated for breast cancer. So that is an aromatic, it sort of inhibits the hormone sensitive. It is important for women who have hormone sensitive tumors to take tamoxifen. So it keeps their breast cancer. It's a drug that is given after chemoradiation for breast cancer. That may influence the endometrial thickness, and sometimes you might find that the endometrium becomes thick and there may be bleeding. And steroid drugs, if you're taking for any other reason, that can also interfere with your ovulation. History of epistaxis, gum bleeding. So this is the past history that you have to take, and each time you're looking at palm, coin and thinking in each of these what is the past history that you need to take. Then menstrual history. So as what we have done, we have taken the history of presenting complaints. We have taken an origin, duration, progress of all these. We've asked for some questions to try and find out whether this bleeding is because of polyp, structural causes, non-structural causes. Then once we finish that, we can go to a menstrual history, obstetric history, past medical history, surgical history and so on. So menstrual history, again, you would have taken that in detail when you asked all the questions. When was menarche? When did it occur? Were the cycles regular initially? When did the irregularity first start? What is the irregularity now? How many pads are changed per day? Are there passage of clots? Is there dysmenorrhea? Have they been taking any treatment for all this? So, these many questions you would ask in the menstrual history. And then you come to the marital and obstetric history. When was she married? When did she first conceive? Was her delivery by cesarean section or by full term normal delivery? Now, this is really important for us to know when she's come now at 45 or 50 with bleeding, whether she had a full term normal delivery or a cesarean. Yes, because in some of these cases you might need operative intervention, like for example is a fibroid and you need to do a hysterectomy. If she's a case of previous 2 CS, you will have to counsel her regarding the possibility of bladder bowel injuries, difficulties during CS while doing the surgery. As such, otherwise whether it was a normal delivery or a cesarean does not impact what you do. However, surgical management, if you were planning, then this will make an impact. What is the obstetric score? P2L2. The last childbirth was so many years back, and was she sterilized or is she not sterilized? If not sterilized, is she using any contraceptives? Why do you want to know whether she is using any contraceptives? Obviously, if there is an IUCD in situ, then that could be the cause of bleeding. Okay, or she could be using some other drugs irregularly, which can cause irregular bleeding. Another common thing is where they take emergency contraception. This is a 45-year-old lady, she is not sterilized. So, she probably does not want to put in a copper T. She has heard of emergency contraception. So, every time there is an unprotected intercourse, they just over the counter, this pill is available and they take 2 tablets of progesterone. What is going to happen? It is going to interfere with that normal menstrual pattern which is there. A few days later, she is going to have some bleeding. Then a couple of days later, she might or might not get her normal periods on time. So, this is abnormal uterine bleeding. So, this is another history that you have to take. Then family history. Again, you think of palm coin. So, with leiomyoma, sometimes it runs in families. You might have a mother or a sister with hysterectomy for fibroids. Malignancies, again you will have to ask for any breast cancer, colorectal cancer, endometrial ovarian cancer, because you have the BRCA gene mutations, you have the Lynch syndrome and such, where you have associations of malignancies of the uterus with the ovary, the endometrium, the breast, etc. So, you have to take a history for any of these malignancies in the family. And also coagulation disorder. You may have a brother or a sister, with some coagulation deficiencies, thrombocytopenias, etc., where you know that then you have to look for these coagulation defects in the index in your patient. So, you have to take a proper family history. Personal history, of course, as with all cases, you will see what her diet is. Is she taking adequate iron, in the diet, which could be in the form of leafy vegetables, fish, chicken, etc., and whether the bladder bowel habits are normal. After the onset of bleeding, if there has been change in the urinary pattern or any problems in micturition, then you know that you are probably looking for a fibroid, which is either in the lower segment or on the cervix. Whether there are any addictions and allergies as for your usual cases. Now, once you finish that, you will come to the general examination. Again, here you have to think, okay, the structural causes are limited to the uterus, but you have your coin, the general causes. So, you will look with, as you go in order, you will see whether the patient is conscious, cooperative. What is a BMI? A patient with PCOS or anovulation is likely to be obese. Someone with recurrent bleeding and not really eating well is likely to be undernourished. Look for that. Look for pallor, look for icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Then you have to look for petechian bruises, because if she's got some coagulation abnormalities, if she's got some bleeding diathesis, then she's likely to have petechian bruises. And you have to look for hirsutism, excessive hair growth on the midline area, on the upper lip, chin, okay, the anterior chest wall, anterior abdominal wall, sometimes on the back. All this will signify that there are hormonal disturbances, there are excessive androgen stimulation, there is no ovulation occurring, and she could be having abnormal bleeding, CO. Palm coin, the O factor, okay, and acanthosis nigricans, that is actually a dark velvety patch on the skin which occurs in the neck, armpits, axilla. It's because of the insulin resistance that is seen along with the polycystic ovarian disease or the PCOD. So, these are aspects that you will look for in your general examination. Of course, the vitals, the pulse, the respiratory rate, the temperature, the blood pressure, and then the general examination. So, you are looking again at all those causes that you were thinking earlier. The anovulation, you could have a thyroid swelling, you might have galactorrhea or milk secretion from the nipples because of your prolactin dysfunction in some women. You can have the hair and skin changes. Okay, as I said earlier, you could have hirsutism, you could have acne, you could have alopecia. If you have a lot of male hormones, then you will have a male pattern balding, okay, and galactorrhea. Then you do a systemic examination. To complete your examination, you must always look for the cardiovascular system, the CNS, and the respiratory system, because again this patient, if she requires surgery, then you must know that all these systems are within normal limits. If not, you have to modify the risk factors associated with all these systems. So, you cannot do away with a systemic examination. So, general examination, complete your systems, the other system examination, and then you have examination of the abdomen. So, again you go in order, you do an inspection, palpation, percussion. In the inspection, what are you looking for? Whether there are any abdominal masses that you can see. So, if there is a leiomyoma, if it is a large fibroid, obviously you will find a swelling or distension of the lower abdomen. So, when you are looking at it itself, you can find that there is a large leiomyoma. Some patients, I mean, they are able to detect even small changes in their habitus. But some women, you find that they come with a huge fibroid which is almost up to the xiphisternum, a large fibroid. They have not even realized that there is a mass growing in their abdomen. So, sometimes it is detected on examination. So, you look at the shape of the abdomen, is it normal? You look at the umbilicus, is it fine? Is there any scar? So, suppose she has undergone cesarean section. So, you will find the scar of the cesarean section. You have to look for a postpartum sterilization scar as well. Many women with full-term normal deliveries would have undergone a PPS. So, that scar will be there. Very often we find dense adhesions to this PPS scar also. So, we have to be prepared. Or she could have had other surgeries, like for example, some children might have had during their neonatal period, they would have surgeries for volvulus intussusception. So, look for all these scars, then look for any visible masses like sinuses, dilated veins, all of which will tell you that there is some abnormality. So, after inspection, then you go on for palpation. Again, you are thinking of all this PALM. On a polyp, you may not be able to find anything on an abdominal palpation. Adenomyosis, sometimes the uterus is enlarged to just above the symphysis pubis. With adenomyosis, you don't get a huge large enlargement like you find in a fibroid. The uterus will be usually 12 to 14 week size. That means it will be just palpable above the symphysis pubis. But with the leiomyoma, you might get a larger mass. Then malignancy, hyperplasia, sometimes only you will find that the uterus is actually palpable. Sometimes you might find that per abdomen there is no mass that is palpable. Then for your structural causes, you may not have exactly any findings on the abdomen, but in coagulation problems or in other hematological abnormalities, you might find that the liver and the spleen are palpable. Any local rise of temperature which suggests any infection, that is another thing that you have to look for. On percussion, usually you will find a dull note on a mass. If there is a fibroid and there is a mass, your percussion will give you a dull note. And auscultation, more often no bruits are heard. So, after that you can just summarize. You have your 46-year-old para 2L2 who is sterilized maybe or not, with complaints of irregular bleeding lasting for so and so months. What is the description of the bleeding in your case? Talk about any other positive history that you have gathered, and complete your, on general examination there is pallor, there are no other findings, and on abdominal examination you have seen a mass maybe, or you have not seen a mass, no other systems are involved, and your diagnosis will be 46-year-old P2L2 with abnormal uterine bleeding for evaluation. So, this is how you will be presenting your case. You may not often be given a full half an hour to present the case, but you will have to, sometimes you are asked to just present a summary. So, when you are presenting a summary, see that you keep this format intact. You start with your presenting complaints, history of presenting complaints, then your past history, maybe your menstrual and obstetric history, any other surgical history, personal history. Just touch upon all that and finish it off within 2 to 3 minutes, because all you get during your exam may be 5 or 8 minutes with the examiner. So, now once you have presented the case, generally the next few questions that you will be asked by the examiner is how will you proceed, or what investigations will you do, or what do you think is the cause of abnormal uterine bleeding in your case. So, depending on what the question is, you will have to answer. Now, we will just go through a normal pattern of what we will do if you have a patient like this. Okay. So, now you must realize that you are doing only a per-abdominal examination. So, your examination as a student you are not expected to do a per speculum or a per vaginal bimanual pelvic examination. So whenever you are asked how will you proceed or what will you do next, you must start with, I would like to complete my examination by doing a per speculum examination and a bimanual pelvic examination. So when you put in a speculum, you can visualize, you look at the vulva, you look at the vagina, you can visualize the anterior and posterior wall, you visualize the cervix. Is there any lesion on the cervix? If there is no bleeding, if there is no excessive discharge, you can use this opportunity to take a pap smear, pap smear to rule out any cervical malignancies, pre-malignant conditions, etc. It has to be done routinely for almost all women where you will be doing a gynec examination. Then you do a bimanual pelvic examination, where you would be trying to assess whether the uterus is anteverted, retroverted, what is the size of the uterus, is it normal consistency, is it very like what you say tender. In an adenomyosis it will be a little more firm and the consistency will be different. Then if there is a leiomyoma, you will find that either it is smoothly enlarged with one single leiomyoma, or you will find that it is irregularly enlarged. So depending on that, you will find what is the shape, the size, the consistency of the uterus, whether there is any tenderness. Then once you finish with the uterus, you will go to the adnexa. So you will find that apart from the uterus, is there any large mass in the adnexa? If there is a mass, again you have to describe how big it is it cystic, is it solid, is it mobile, is it tender? So these are the things that you have to do on every physical examination. If you can remember that all your findings should be there in every examination, it will help in some case or the other. Once you've looked at the uterus and then found out both the adnexa, you can go to the posterior fornix and see if there are any deposits, scarring, etc. on the posterior fornix, which might be suggestive of endometriosis, where you could have coexistent adenomyosis. So there are some pathognomonic features that you will find on examination. For example, if there is a fibroid, you're supposed to do a transmitted mobility. When you move the cervix, you will find that the uterus also moves. You can palpate that by your upper arm. So you know that this mass that you're feeling is from the uterus, it's arising from the uterus. If it doesn't move, then it's probably an adnexal mass, which will not move when you manage to move the cervix. Okay. Similarly, if there is pain on movement of the cervix, that will tell you that posteriorly there are some adhesions, there are some deposits, which could be endometriotic, it could be malignant, because of which the patient is experiencing pain. So you have to complete your examination, your physical examination of the uterus, the adnexa, and take a pap smear. Now once that is done, what is the next step? So you've done a history, you've done an examination, you've completed your examination. The next step in evaluating this patient would be laboratory investigations and imaging. Okay, because the first thing you have to do is rule out structural causes. So you do some laboratory investigations, you do an imaging, and depending on that, you may or may not take a sample from the endometrium to know whether there is any endometrial pathology. That is something that you cannot make out on just imaging. You need a histopathological examination of the endometrium. And then you come to a diagnosis as per palm coin, and then you manage. So this is how we usually go about. Now, what are the investigations that you will do first? Obviously, you want to know what is the hemoglobin level. If she is having bleeding for so long, is she anemic? So you will do all investigations for anemia. If she is anemic, you might also like to do a peripheral smear, maybe a serum ferritin level, to try and find out whether there is iron deficiency coexisting, whether she's been on a good nutritious diet, etc. And then you will have to do other investigations to look for structural investigations will come up on imaging. What about the coin set of causes of the palm coin group? Okay, for that you will have to do maybe a test to look for bleeding time, clotting time, what are the platelet count, what is the thyroid function test, okay, what are the other investigations that you do from the coin part of you. So before you do all this, the first thing that you have to remember, in any woman with reproductive age group who comes with abnormal uterine bleeding, the first thing to do is rule out pregnancy. It does not need that a patient is married or that she's having, like whether she tells you that she's 45 years old, she's only 19 years old, she's only 16-year-old. None of this makes a difference. If a woman comes to you with irregular bleeding. Now, what do I mean by irregular bleeding? It doesn't mean that heavy, frequent, prolonged. She might say that she has amenorrhea. Okay, 3 months, 2 months. But she says her cycles are always irregular. From the time she's started her mena, she's having cycles only every 2-3 months. Now it is 4 months. But if you do not do a pregnancy test, it is quite criminal to miss a pregnancy when a patient comes to with you with these symptoms. We've had unmarried girls coming with ectopic which has ruptured and has led to death because someone has not done a urine pregnancy test. So, it's very important to do a urine pregnancy test. Never forget pregnancy. Very often you will find patients saying, no, no, even it's a married woman staying with her husband, she says, no, no, I don't think there's a chance of a pregnancy in this cycle. But it's always better to document it, prove it that the urine pregnancy test is negative. So, that is one thing. Then the other laboratory tests that we'll do, as I said, history of heavy bleeding, you will do a complete blood count and all that is required for investigations of anemia. Rule out pregnancy. You have to rule out thyroid dysfunction by doing a TSH of free T3 and T4 levels. And coagulation, if dysfunction is suspected, you have to do all tests like a bleeding time, clotting time, your PT, APTT, etc. All the tests for bleeding tendencies. Okay. Now, what about imaging? So, imaging is looking for structural problems in the uterus, and with the advent of ultrasound, our diagnosis, management, etc. has, it has improved by leaps and bounds. So, you cannot withhold a scan from a woman who has come with abnormal uterine bleeding. It does not have to be done at the first episode. You may leave her alone, means if you might try some drugs which is the first episode and she responds to your treatment, it's fine. But if history and clinical examination are normal, you may not do a scan. But even with a normal physical examination, without doing a scan, you cannot find out what the endometrial thickness is, whether there is any small pathology like an endometrial polyp. So, especially for a woman with persistent bleeding, especially the woman is more than 40 years where she is likely to have pathology, a minimum an ultrasound scan of the abdomen, the pelvis has to be done. So, you can do a transabdominal scan or you can do a transvaginal scan. Large masses which are on the abdomen like large fibroid, you will need a transabdominal scan. For a small uterus, it's always better to do a transvaginal scan because the probe being very close to the uterus, it's easy for you to find out the structure, the echo texture of the myometrium and the endometrium. You might need a Doppler sometimes to find out how much vascularity is there, whether this is a very vascular lesion or not. For polyps, like for example, you have a polyp and you find that there is a Doppler showing the flow of a single vessel which is coming to it, then you know it's a polyp. Sometimes if the flow is from the periphery and it's a slightly larger mass, then it could be a submucous leiomyoma. And you can do a saline infusion sonography, an SIS or a saline infusion sonography. So, by doing that, what you are doing is you are injecting around 10 to 20 ml. You put in a small Foley's, number 8 Foley's into the uterine cavity. Okay, so this is the uterine cavity. You put in a small Foley and you inflate the bulb. And then you flush the uterine cavity with around 10 cc of fluid. Now, what happens? That fluid distends the cavity, and as the cavity distends, if there is a polyp, you will find that there is a small polyp that is occurring. You can see that. Okay. Similarly, the rest of this fluid will then flow out through the tubes. It will also tell you that the tubes are patent, though that is not our main aim in doing the saline infusion sonography in this case. So, that is. So, when you do images, when you do an imaging, what all can you find out? You can find out whether there is, so you have this uterus, you might have bigger fibroid, small fibroid, okay, you can have all sorts of fibroids. You might see a small polyp in the endometrial cavity. You might find that this myometrium here is heterogeneous because of the seepage of blood and fluid from each cycle. You will find that the myometrium is cystic, it's heterogeneous, it's showing a different echo texture. So, that means she has adenomyosis. Sometimes you might find that you have the uterus where how much do you expect that the endometrium is seen in a woman of the reproductive age group. The endometrial thickness is normal if it is between say 10 to 12 millimeter towards the end of the menstrual cycle. That means just before her next periods. But if you find that the endometrium is say 25 millimeter, 18 millimeter, then it is thick. So, otherwise when you examine this patient, her uterus will be normal size, there will be no adnexal mass, a very nice well defined uterus. But if the endometrium is thick, she needs other investigations. Okay. So, this is how you will do. A saline infusion sonography also requires an ultrasound. So, these are all the advantages of ultrasound, or what all conditions you can diagnose using an ultrasound. Okay. Do you need to do hysteroscopy? Now, what is a hysteroscopy? Where just like you do a laparoscopy and you take an incision, small incision through the umbilicus and you visualize the inside of the abdominal cavity. Similarly, you have a flexible scope with a lens system at the tip which allows you to visualize the endometrial cavity. Okay, so the cavity is a collapsed cavity. In order to visualize it, you need to distend it. Otherwise, you will not be able to see both the walls. So, in order to distend it, what do? We flush fluid. Okay, so we have a system where we connect a fluid, either it is a colloid or crystal. Sometimes we use glycine, or we can just use normal saline, which is introduced into the cavity. The walls of the endometrium are distended, and you can see the endometrial cavity, you can see the polyp. And not only that, it's not just visualization, it is also therapeutic, because you can use your operative instruments to either remove that polyp or to take a biopsy from any suspicious area. So, when you do a blind, otherwise we will be going to the next step. After imaging, the next step is the histopathology. So, when you do, what are the techniques that you can use for sampling the endometrium? You can either just do a curating, or you can do an endometrial aspiration, or you can do a hysteroscopic directed biopsy. So, when you do a curating or an endometrial aspiration, it is essentially a blind procedure where you are just introducing instruments into the endometrial cavity and curating blindly. It is said that just around 25 to 50% of the endometrium will be sampled when you do a blind procedure. So, you can overcome that by doing a hysteroscopy, visualizing the entire endometrium, finding out where the localized area of pathology is, and taking a directed biopsy from there. So, that is the other advantage of hysteroscopy that we have. It can be an OP procedure, what is called office hysteroscopy, because you can use a very thin scope where you do not need to dilate the cervix. Okay, but if you need to do operative procedures, then of course you have to have a regular theatre. You need to dilate the cervix, which can be done by using a misoprostol the previous night, or by doing a rapid dilatation with Hagar's dilators. And then you introduce a scope, distend it, and you take a biopsy from wherever you want, or take the polyp. You can see the polyp and then remove the polyp, do a polypectomy as well. So, if you are doing an operative procedure, then you would need anesthesia. Otherwise, the patient is quite comfortable under local anesthesia. So, that is hysteroscopy. So, if it is such a good technique, would you do an hysteroscopy for all the patients? Definitely the scope is costly, so that means that much of you need infrastructure, the patient cost will increase. So, you do not have to do a hysteroscopy for all the patients. There are some women in whom an hysteroscopy is indicated. For example, a lady with intermenstrual spotting, she is likely to have a polyp. And this polyp, if you do a blind sampling or a blind DNC, you are likely to miss. So, in this case, you are justified in doing a hysteroscopy. Similarly, if you do a scan and you find that there is a focal area of thickening in the endometrium, otherwise the endometrium seems to be normal, but when you do a Doppler as well, there is some abnormal vascularity, there is some abnormal echo texture in a focal area. So, when you do a DNC, you are not sure whether you will sample that particular area, in which case you can do a hysteroscopy. Or if there is a dyssynchrony, for example, you have done an endometrial, she is having very much symptoms, and you have done an endometrial sampling, and you find that the sample report has come as normal. It does not explain the severity of her symptoms. So, then instead of doing a simple repeat sampling, you can use a hysteroscopy to repeat the sample. And if you get an inadequate histopathology, sometimes when you do a sampling, the histopathologist will tell you that the sample was inadequate for them to give you a report actually. So, you need a repeat procedure, in which case it would probably be better to do a hysteroscopy. Similarly, if there is no response to medical management, you have done a sampling, you had a report, you have started her on medical management, but the patient is not responding, then it is probably you are missing a small polyp or a focal area of malignancy. It is always better that you go ahead and repeat the procedure with a hysteroscope. So, these are some indications for hysteroscopy. Okay. Now, when you are going, there is a protocol that you need to follow with the endometrial assessment. So, once you have done a hysteroscopy or an imaging and you find that there is a fibroid, now you know that this fibroid is giving rise to the bleeding, there is probably no need for further testing. Now, if a patient with a leiomyoma is having regular cycles with just heavy bleeding during those 4 or 5 days, then you know that this bleeding is because of the leiomyoma. There is no need of doing an endometrial sampling. But if the woman is above 40 years, she is also obese, she is showing features of polycystic ovarian disease, and she is not just having heavy menstrual bleeding, she is also having prolonged cycles, irregular cycles, maybe intermenstrual spotting, then this is a woman where you know that there is a leiomyoma, it could be the cause, but you must exclude another cause as well. So, you will have to do a sampling for these patients to see whether there is no pathology in the endometrium which requires a different line of management. Now, when you do an endometrial assessment, how would you like to do the endometrial assessment? It is recommended in all women with AUB who are older than 40 years of age. That is a very important aspect. If the woman is more than 40 years of age, it is best that you have a sample and a histopathology report before you start her on hormones. If she is less than 40 years of age, then you may just give her a set of treatment, see whether she responds, and then leave at that. But if she has any risk factors for endometrial cancer, what are these? Like she could be obese, she could be having a family history of any malignancies, she could be having breast cancer previously. So we just look at that. If any of them are having a risk of endometrial cancer, even if they are less than 40, you will have to do an endometrial sampling. And how will you do this endometrial sampling? As I said earlier, a DNC was what we were doing traditionally over the last so many years. For that you have to take the patient to the theatre, you have to dilate the cervix and then take a sample. So that means anesthesia is needed. And now we have what is called PIPEL or endometrial aspiration, by which without dilatation a very thin cannula is introduced into the uterine cavity and you have a syringe at the end. So once you move it and you can aspirate it, they say that you are more likely to get a positive report. Okay. Now recent studies are showing that there could be an issue about this, whether a DNC is better or endometrial sampling is better. But for current purposes, we think that an endometrial sampling is good enough. But we must remember that there could be issues, and if there is a problem, we need to repeat with a hysteroscopy. And as I said earlier, a hysteroscopy you would do only in certain situations. If the endometrium is thick on imaging, focal thickness, not responding to medical management, etc. Now, who are the patients who require an endometrial biopsy? As I said, young women who are at risk for endometrial cancer. Who are these? These are women with irregular bleeding, especially if not responding to treatment. Women who are obese, women who have an endometrium which is very much thick, more than 12 millimeters of endometrial thickness. Those who had early menarche, not going in for menopause, late menopause, those who are nulliparas, those who had treatment for infertility, anovulation. All tells you that there has been prolonged estrogenic stimulation of the endometrium without a progesterone's protective effect. So that is what happens in a normal cycle. You have estrogen which causes proliferation, then you have progesterone which comes and protects and secretory changes, and then that endometrium is shed. So there is the risk of malignancy reduces. But if you do not have ovulation and you have estrogen working on proliferating, there's so much cellular activity going on, it's very likely that it can go out of control and change into neoplasia or malignancy. So PCOS, nullipara, infertility, these are all risk factors for endometrial cancer. Diabetes also. Any history of other cancers like malignant disease of the ovary, breast, endometrium, colon are also risk factors. Any hormone therapy which could be given either for this irregular bleeding, maybe tamoxifen for breast cancer, unopposed estrogen therapy, though we don't really use that when the woman has an intact uterus. So these are all indications where an AUB is not responsive to medical management, or as I said earlier, syndrome where the colorectal cancer, the Lynch syndrome. These are women who are at risk for endometrial cancer. If these women come even at 35 or 38 with irregular bleeding, it's always best that you sample the endometrium and then start them on drugs. Now, when you do the endometrial biopsy, these are some of the reports that you will get. You must know what to do with each of these reports. So, if you have a patient who is having ovulation, then she will have proliferative phase and she will have a secretory phase. Always, whenever you're doing an endometrial sampling for a woman with irregular bleeding, you need to sample in the second half. Why? You're waiting for all the hormonal effect of that cycle to have taken place and just before the endometrium is due to shed. So, premenstrually is when you will sample. Okay. And if she has had an ovulation, what is going to be the pattern of the endometrium in the premenstrual phase? Obviously, it's going to be secretory. So, if you get a secretory endometrium, then you know that the woman is not having much of a hormonal disturbance. This is not AUBO. Okay, the hormones are normal. Is there any other reason? Then is what you have to look for. But if the ovulation is not occurring, then what are you going to get? You're going to get that estrogenic proliferative pattern. So, if you get a report which says proliferative, it tells you that there is no ovulation. So, this is anovulatory. So, this is most likely to be AUBO. Suppose she also has some features of adenomyosis at 45, then your diagnosis is going to be AUBA with O. Okay. So, you are looking for proliferative and secretory changes which usually are there. Now suppose you have a postmenopausal lady who has had menopause for 5 or 6 or 10 years and then she comes with bleeding PV. If you do a sampling, sometimes you might get a report of atrophic. It is not very common to get that in a premenopausal woman. And infections might show up as endometritis. If you treat the endometritis, generally the bleeding is taken care of. Okay. Now these are some of the reports that you get. What are the other common reports that you get? You will get what is called disordered proliferative endometrium. What does that tell you? Again, it is similar to your proliferative endometrium in the sense there is no ovulation. But there is proliferation which is really a little bit disordered. And if you leave it like that, soon it's going to go into hyperplasia. So if you find that there is disordered proliferative endometrium, again you need to treat. How would you treat proliferative or disordered proliferative endometrium? Now, as you know, what we've said earlier, why is it proliferative? Because there is no progesterone effect. Because there is no ovulation, there is no progesterone effect, continues to remain proliferative. So how would you treat? You would treat by giving exogenous progesterones. Okay, that we will come to later. When to give, how to give, we will come to later. So you will treat with progesterones. Then you could have hyperplasia. As I told you all earlier, hyperplasia was initially classified into 4, but now we use the terms hyperplasia without atypia and hyperplasia with atypia. So if there is no atypia and there is just hyperplasia, again it tells you what? That this continuous estrogen action for a long time. So it was proliferative, disordered, but now it's gone into endometrial hyperplasia. So how would you remedy the situation? Again you need progesterones. So you might need progesterones for continuously or for a little longer period of time. And with hyperplasia, with or without atypia, if you are going to treat with progesterone, you need to follow up, repeat the sampling after 6 months and see whether this hyperplasia has regressed. If it has not, you might have to change your plan of treatment or continue your medication for some more time. Now what happens if you find atypia? What is atypia? Basically where there is too much of cellular mitotic activity and it's going from an organized picture to a disorganized picture. There is no malignancy. What is malignancy? You will find that the nucleus is very big, there are too many cells, the cells are not arranged very well. There is a typical picture that you get in a malignancy. Here, the frank picture of malignancy has not been attained. However, there are features which suggest that there is atypia. Okay. So if there is atypia, then depending on the situation, it's better that you usually go ahead with a hysterectomy. So if it's a 40-45-year-old lady who has completed her family and she has endometrial hyperplasia with atypia, her risk of developing malignancy in the future is around 20 to 30%, which is a high risk. So it's better that we counsel these women and we take them up for hysterectomy. However, very rarely you will find some women coming a little earlier, say 36, 38, they have not completed their family, they do not have children and they have endometrial hyperplasia with atypia. Now we are telling them that we need to do hysterectomy because they have a chance of developing malignancy, but they do not have a malignancy now. So if they are not willing for hysterectomy, then we need to give them high dose progesterones, which can be either given orally or you can put in an LNG IUS, a levonorgestrel intrauterine system where the progesterone is delivered in the uterus slowly and gradually over a period of 5 years. So you can put in that, but you have to again follow up this patient, do a repeat sampling after 6 months, see whether the atypia has regressed. If it has regressed, you discontinue the progesterone therapy. You ask them to go in for maybe assisted reproductive techniques or whatever it is so that they can conceive soon. And once a family is completed or once they have a conception and have a pregnancy, then they can go in for a hysterectomy. If they do not go in for a hysterectomy, then obviously they need close follow-up, which will involve ultrasound scans maybe and a repeat sampling as and when required. So that is atypia, where you have to be careful and you would like to do a hysterectomy. Sometimes, of course, you might get a report of a frank malignancy, adenocarcinoma, or CA endometrium, wherein obviously the treatment will be according to the stage of the disease and what are the other risk factors that are present, the type of the disease, the type of CA endometrium, type 1, type 2, what is the stage and what are the risk factors, the kind of carcinoma that is there. So that is how these are the various reports that you will get when you do the sample, and this is how you decide how to treat. Okay. So Now, I've given you the battery of investigations. I've given you all those blood investigations. I've given you some imaging, which is TAS, TVS, transvaginal, saline infusion sonography, Doppler, and then there is sampling, which can be either hysteroscopy directed sampling or not. Now, which of these, would you do all these for every patient? Once you find that there is CA endometrium, you might do an MRI. So, you will not do all these investigations for every patient. The investigations that you choose will depend on what is the age of the patient, what symptoms she has, etc. Why is that important? Because depending on the age, you will have certain conditions that are more common, certain conditions that are not very common. So, you can divide it into adolescent, reproductive, perimenopausal or postmenopausal age group. So, when you have a premenarcheal child, then the causes of bleeding are different. It could be a foreign body, it could be because of estrogen withdrawal, and sometimes it can be malignancies. So, you have to investigate accordingly. You might need to do a MRI, CT, because sometimes the examination will not be complete. Okay, so that depends. Now, suppose it is a lady, is an adolescent girl, then you have to rule out pregnancy. This is the early part of the periods where she's just probably had a menarche. This may be the first sign of a coagulation abnormality, like your von Willebrand's diseases, your some hemolytic anemias. These could be the first indicator that the patient has a coagulation defect. And of course, you must realize that it could be also because of hypothalamic immaturity, because her the system, the hypothalamo-pituitary ovarian axis has not become mature. Ovulation is not occurring because of that. So, you give her time, just manage her symptomatically, and you might be able to tide over. Then once the maturity sets in, cycles will be regular. Or it might be psychological, or she might be having some sexually transmitted infections. So, you have to take a proper history and do the investigations accordingly. In a reproductive age group, it's like whatever we've seen, pregnancy, anovulation, your palm coin set of causes. Okay. And towards the menopausal age group, then what happens, or in the postmenopausal age group, your carcinomas are seen more frequently. Like maybe 30-40% of the women with AUB may have some or the other form of malignancy. So, you will have to look for that. Look for whether they are on hormone replacement and the problem is because of that, or they are on some drugs like tamoxifen because they've been treated for CA breast. So, you have to look for all those causes. So, that is what is called a life cycle approach. Depending on the age of the patient, the investigations that you do will be different. Similarly, symptomatology. As I told you earlier, suppose a lady has intermenstrual bleeding. Then you have to look for an endometrial polyp. You may not see that on imaging alone. So, you might need hysteroscopy. Okay. And then when you look at the cervix, you might find that there is a lesion on the cervix. Obviously, you need a pap smear, you will need a cervical biopsy and so on. If it is so a patient with polyp, if it's an endometrial polyp, they will present with heavy menstrual bleeding, intermenstrual bleeding or postmenopausal bleeding. If it's a cervical polyp, again they might present with intermenstrual bleeding or postcoital bleeding. So, postcoital bleeding is another important symptom. If you find that the lady is coming with postcoital bleeding, definitely you have to do a pap smear, you have to do maybe a colposcopy or a cervical biopsy as and when required. Okay. If it is AUB-A, adenomyosis, this lady is likely to be in the perimenopausal age group with dysmenorrhea, heavy bleeding and so on. If it's a leiomyoma, if it is submucosal, then the patient is likely to have heavy menstrual bleeding. I told you all earlier, if it is a submucosal leiomyoma which is near the endometrial cavity, then there is likely to be heavy menstrual bleeding. But if it is an intramural or a subserous myoma, there is likely to be more pain, maybe dysmenorrhea. And then of course malignancy, which could be endometrial or cervical. There could be irregular bleeding and associated other general symptoms like weight loss, loss of appetite.